Hello friends, welcome back to this new lecture topic on anemia. Thank you for subscribing this channel. Today we will talk about anemia. What is anemia? Anemia can be defined as reduction in the oxygen carrying capacity of the blood. As we all know that on a routine blood test, when you do a complete blood count, you have hemoglobin and a hematocrit as different components in it, and these two components are required in order to diagnose anemia. You can say, or you can define it as a reduction of total circulating red cell mass below the normal limits, as a consequence of which, or the result of which, is that tissues suffer from hypoxia because they are not getting enough oxygen. The major function of hemoglobin is to carry oxygen, and when the amount of hemoglobin is reduced, tissues tend to suffer from hypoxia. As a result of which, when patients complain to you of symptoms of anemia, they are all because of tissue hypoxia. As we go through the further discussions, you will see what different aspects needs to be looked at when you are diagnosing anemia. And at the bottom I have mentioned two things. One is hematocrit and the other is the hemoglobin. Hemoglobin is the protein that is present in your RBCs which carries the oxygen. Hematocrit is the part of total blood volume which has RBCs, which comes roughly to 45% of your total blood volume. Remaining 55% is plasma. So these three things, hemoglobin, hematocrit and RBCs, should be taken into account when you are labeling somebody as anemic. In the bottom I have put in some tricks, and they are as follows. One is acute blood loss. What happens when there is acute blood loss? You're going to lose the total blood volume, hence you will be losing plasma and the hemoglobin, that is the hematocrit. So when you measure your hemoglobin or the hematocrit or the RBC count, all three are normal. So a patient who comes in with acute upper GI bleed or acute lower GI bleed, you do a complete blood count, you'll be amazed to see that their hemoglobin is normal. However, within the next 24 to 36 hours, what happens is body tries to retain fluid and hence plasma volume increases. However, hematocrit does not. Hence you tend to see fall in the hemoglobin 24 to 36 hours after an acute episode of blood loss happens. Same thing with dehydration, where you are losing fluid from your total plasma volume. Hence, the hematocrit might appear elevated. This is especially true in patients who are in long-term care facilities and are those who cannot take oral intake, like demented patients. Late pregnancy. There are a lot of changes that happens. In blood, the plasma volume expands by 50%. However, the RBC mass expands by 25%. So you tend to see more plasma expansion than the RBC volume expansion. Hence, you will see relative dilutional anemia with late pregnancy. If in fact there is actually increase in the number of RBCs that happens, but still they will be anemic. The WHO criteria to say who is anemic and who is not, you can take these simple guidelines where men with a hemoglobin of less than 13 and women with a hemoglobin of less than 12 are called as anemic. There are other studies and um, organizations that have taken different aspects like age, sex, race when determining who is anemic and who is not. How do you classify anemia? I think one should be aware of two different classifications. One is classification based on pathophysiology, and I think that helps you when you try to investigate a case of anemia. And if you know this classification, I think this is very helpful. The other classification will be based on morphology, and that will guide you in terms of approaching a case of anemia. So let's start with this first classification. Number one is the blood loss, which is the acute or chronic. Number two is your increased red cell destruction, that is hemolysis. And third one is decreased red cell production, mainly problems with the bone marrow. Some of the causes for hemolysis. If you look at the RBC, a single RBC has a membrane, has a cytoplasm and a nucleus. Nucleus is almost disappears in a mature RBCs. The defects in the membranes, be it inherited like hereditary spherocytosis, hereditary elliptocytosis, enzyme deficiencies within the cytoplasm like G6PD deficiencies, pyruvate kinase deficiency, glutathione synthetase deficiency. Problems of the hemoglobin which is there in the cytoplasm like reduced formation of hemoglobin which is thalassemias, alpha and beta thalassemias, or abnormally formed hemoglobin which is sickle cell anemia or hemoglobin C disease. If you look at the acquired cause for the membrane defects of the RBCs, then you see PNH, which is paroxysmal nocturnal hemoglobinuria, a very interesting disease one should be aware in terms of board questions. Antibody mediated, a very important thing is the autoimmune anemias, which includes warm antibody type, which is IgG associated with CLL, SLE drugs as well, cold agglutinin type which is IgM and seen with mycoplasma and syphilis, and third one is paroxysmal cold hemoglobinuria which is less common. Transfusion associated hemolysis and drug induced hemolysis, especially with ticlopidine and cyclosporin. Mechanical trauma, there is something called as microangiopathic hemolytic anemia, wherein there is thrombus formation in microvasculature leading to squeezing of the RBCs when they are passing through the capillaries. That happens in hemolytic uremic syndrome, disseminated intravascular coagulopathy, thrombotic thrombocytopenic purpura TTP. Then the prosthetic heart valves is where there is mechanical shearing of RBCs. Sometimes marathon runners can also have hemolysis because of the mechanical trauma. Infections, especially when these parasites go and sit within the RBCs, they lyse when they come out. So malaria and babesiosis. Sequestration, as it happens in hypersplenism, because spleen is the organ for destruction of the RBCs. What are the causes for decreased red cell production? And that basically includes your factors that are needed for formation of hemoglobin and nucleus maturation, hence vitamin B12 and folate deficiency, iron deficiency anemia, anemia of chronic disease. You tend to see this frequently, more so in Western world, reason being that there are a lot of inflammatory diseases that happen. And the basic idea behind anemia of chronic disease is there is failure to mobilize the stored iron from macrophages into the bone marrow for actual RBC synthesis, and hence the stores of the iron are there adequately, but there is no way to transport it to the bone marrow. Thalassemic disorders, we talked in hemolysis as well, and they can be included in decreased red cell production as well. Acute leukemias, basically the bone marrow, which is the space for erythroid synthesis is overtaken by other cell lineages. Hence, acute leukemias, myeloproliferative disorders can be the reason. Aplastic anemia, wherein there is an autoimmune reaction to the stem cells forming myeloid stem series, and hence they will be thrombocytopenic, anemic, and neutropenic. Fanconi's anemia, Fancy syndrome, which is associated with pancytopenia, parvovirus B19 infection, bone marrow suppression from chemotherapeutic agents, and we already talked about anemia of chronic disease. Just to stress once more. What are the symptoms of anemia? Basically, it includes fatigue, dyspnea on exertion, palpitations, pica, which is basically people tend to have a tendency to eat ice chips, and kids tend to have the tendency to eat mud, and that is classically associated with iron deficiency anemia. So also chelosis and koilonychia, which is spooning of the nail fingers. Anemia can also cause exacerbations of CHF, MI, or arrhythmias. Sometimes people can have confusion. Now, before we move on to the second way of classification, I think one should be aware of these terminologies. They are called as red cell indices, and they are very practical. Number one is mean corpuscular volume, which is MCV. It's the average volume of a single RBC. Normal is 80 to 100 femtoliters. MCH is a mean corpuscular hemoglobin. It's the average hemoglobin that is present in one RBC. MCHC is a mean corpuscular hemoglobin concentration, which is nothing but the amount of the hemoglobin to the given volume of the RBC. So it's slightly different from MCH. Red cell distribution width is the different sizes of RBCs. This is also a very useful test in diagnosing anemia. How do you classify based on morphology? Remember, in the beginning of the talk I said there will be two classifications. One is based on the pathophysiology and the second one is based on the morphology. Why one needs to be aware of this classification is this is how you would clinically approach to a patient when you see anemia on the blood work. And you classify based on the MCV and the hemoglobin concentration in the following ways: normocytic, microcytic, macrocytic, dimorphic, which includes both, and then based on the hemoglobin, either it could be normochromic or hypochromic. What are the causes for microcytic and hypochromic anemia, which means MCV is less than 70? So when I see a patient who has anemia on the labs, my next step is to look at MCV. That is my first, and that will tell me whether a patient is microcytic, normocytic, or macrocytic. Based on that, you further investigate. And what are the causes for microcytic anemia? Number one, iron deficiency anemia. Number two, anemia of inflammation. Number three, thalassemias. Number four, sideroblastic anemias, where there is problem with synthesis of heme part of hemoglobin. Lead poisoning, something similar, you can call it as acquired sideroblastic anemia, and copper deficiency. Causes for macrocytic anemia includes reticulocytosis, alcoholism, vitamin B12 and folate deficiency, drugs like hydroxyurea, which interferes with nucleic acid synthesis, methotrexate, commonly used drug, zidovudine, an antiretroviral drug, azathioprine and capecitabine, which is your chemotherapeutic medication, myelodysplastic syndromes, a very important disease, and hypothyroidism, where metabolism is slowed in each and every individual cell. Hence you tend to see that nuclear maturation does not happen, leading to big cells macrocytic anemia. How do I approach a patient who is anemic? Obviously, you start with your history and physical exam. certain things will guide you towards a certain particular type of anemias. What I try to look is if there are any culprit medications that can be causing anemia. Look for any pallor, which is a clinical sign of anemia, jaundice, lymphadenopathy, and hepatosplenomegaly. These can point towards hemolytic anemias, anemia associated with some lymphomas or leukemias. If you remember this slide, I think it will be a lot easier for you in terms of approaching a patient who is anemic, be it on boards or once you are in a clinical practice. Look at this slide. When you look and determine that patient has anemia, the next step, as I was talking to you, is to look at MCV. If MCV is less than 80, it's a microcytic anemia. Next step is to order iron studies. What does iron studies include? It includes serum iron, a total iron binding capacity, percent saturation, and ferritin. I will tell you in detail as to what these different things represent in terms of physiology, because based on that you will be able to interpret into what happens in different diseases. Just remember for now that low iron and ferritin with a high TIBC is nothing but it's the number of receptors that are available on the bone marrow for iron to bind. So if iron is low, then the bone marrow becomes more sensitive to bind to that low iron which is present in the blood. Hence your TIBC increases in iron deficiency anemia. However, in anemia of chronic disease where there is plenty of iron available, but there is problem in mobilizing that iron, hence body knows that, and hence bone marrow does not increases the number of receptors, hence your TIBC will be low and ferritin will be high. There is something called as Mentzer's index, which is basically a ratio of MCV over RBC. If it's less than 13, it's suggestive of thalassemia. If it's more than 13, suggestive of iron deficiency anemia. The logic behind it being that in thalassemia, there is no reduction in the number of RBCs that are produced. Hence, your denominator RBC will remain high, whereas MCV is reduced. Hence, that ratio will be low. Whereas in iron deficiency anemia, even the number of RBCs that are produced is low and MCV also goes down. So both numerator and denominator goes down, your ratio goes up. Next, moving on to MCV, which is normal. So what you do next? Look at the retic count, because reticulocyte count tells you the bone marrow function. It's the best way to look at the bone marrow. You don't need the bone marrow biopsy right away. So look at the reticulocyte count. If it's not proliferating, it means that there is problem with the bone marrow, like aplastic anemia, like lymphoproliferative disorders, or red cell aplasias. If it's proliferating, then what does that mean? That means there is something that is hemolyzing the RBCs, and hence there could be a hemolytic anemia, or there might be some blood loss that is happening, like a chronic lower GI or upper GI bleeding. How about MCV, which is high? Falls into the category of macrocytic anemia. And then you look for segmented neutrophils on the peripheral smear. Normally, a neutrophil has two lobes on the nucleus. A segmented neutrophils would have 4, 5 or more. And that you call it as Pelger-Huet anomaly. When you see megaloblasts, which usually goes with vitamin B12 or folate deficiency, when you don't see them, then it goes with alcohol abuse, myelodysplastic syndrome, liver disease. The reason is not clear why you tend to see big cells, but one theory is lipid deposition onto the membranes of the RBCs, making them look bigger. Congenital bone marrow failure syndromes. This is the slide which I was talking to you about, is different iron studies and what happens with individual diseases. Serum iron is basically your iron in the blood. TIBC transferrin, which I told you it's nothing but the receptor activity for binding iron. Ferritin is your stored iron, which is present everywhere in your body, and this is what, let's look at it. So iron deficiency anemia, there is no iron, hence iron level goes down. Receptors becomes more sensitive because there is no iron to bind, hence TIBC goes up, and there are no stores as well, so ferritin goes down. Anemia of chronic disease, where there is plenty of iron but cannot mobilize. So your serum iron will be low because you are not able to get that iron from the stores into the blood and give it to the bone marrow. TIBC will be low because you have plenty of stores of the iron, and hence body is sensing that, but it's not getting enough to the bone marrow, hence that will be low. Ferritin, which represents your stored iron, is normal to high. Sideroblastic anemia, there is a problem with hemoglobin synthesis, hence you have enough iron, which is usually ferritin is elevated, sorry, the serum iron. TIBC can be normal or elevated, and your ferritin, which is stored, will be high. Thalassemias can be normal to high for all those three things. How would you evaluate a hemolytic anemia? When you see that hemolysis that happens, when should we consider hemolysis? Is if there is a rapid fall in hemoglobin concentration, or you see reticulocytosis or abnormal shaped RBCs. You measure lactate dehydrogenase and you see haptoglobin, which is nothing but a protein which tries to bind to the hemoglobin and then gets excreted into the kidneys. So when you have hemolysis, the free hemoglobin in the blood goes up, that will bind with haptoglobin, and hence your percentage of the haptoglobin drops. So when you see increased LDH and reduced haptoglobin, there is 90% specificity to diagnose hemolysis. So going back to this slide, if you see, we touched the low MCV part, we are touching this part now because this part requires a bone marrow biopsy to further diagnose. Now the hemolytic anemia is the one which needs to be further diagnosed. If possible, try to distinguish if it's intravascular or extravascular hemolysis. When there is extravascular hemolysis, so it is being hemolyzed in the spleen, so jaundice, anemia, and the splenomegaly will be present. If it's intravascular, you tend to see anemia, hemoglobinemia, because there is hemoglobin in the blood. That hemoglobin excreted into the urine becomes hemoglobinuria. It can be converted to an intermediate metabolite, which is hemosideruria and jaundice. With this, I end my talk. Thank you for watching this.